Everyone having a good conference so far? Nice, nice. So yeah, this is obviously this is called What Interfaces Are Right for Your Practice. Obviously, ultimately, you guys are going to determine what interfaces are right for your practice. But our hope is that we can kind of tell you a little bit about the nuts and bolts of what the different interfaces, integrations, whatever you like to call them, are and do, and what use cases they've served so far. So, you know, when you guys are talking to whoever it is, that HIE, that ACO, that CIN, that payer, and they say they need X, Y, and Z and throw some letters and numbers at you, it makes a little bit of sense and you know what to come talk to PCC about. That's not to say you guys have to completely own that stuff. Obviously, we're happy to meet with the third parties and help you iron it out, but just to give you a little bit of context for what the common integration use cases we see are and what we sort of support out of the box for you on that. I'm Scott Kirby. I do the, excuse me, I work on our clinical data exchange team. I sort of swap hats between a technical role and a strategic role. So because of that, it'll often be me on that call with you and the third party, figuring out what exactly you do need to meet your integration goals with them. And oftentimes it'll also be me going and pressing buttons to make those things happen with computers. Though we also have a great team of other developers who do that as well. So, yeah, so session goals, right? A high-level survey of clinical data integration options offered by PCC, just sort of what we do. Understanding common use cases for those integration methods, how they're gonna work for you. Oh, memes, I put memes in here, that's right, yeah. So figuring out what data I need to send to my HIE, IIS, CIN, ACO, RHIO, maybe some of you guys know what that is, but that's a specific one. XYZ, that's obviously a joke. Yeah, but seriously, I mean, there's a million outfits out there today who want all sorts of different types of data to meet quality measures, for population health reporting, for payer incentives, you name it. And it seems like it's not changing anytime soon. It's not going to go back in the other direction. It's going to be more and more data sharing requirements and incentives and so on and so forth. So we want to help you guys meet that need. More memes, nice. Yeah, and PCC can help you with that. So we're gonna, our goal in general at PCC obviously is to remove the obstacles that keep pediatricians from practicing medicine. And so we want to get as much of the data sharing concerns out of your way as possible and make it so that, just using PCC enables you to share the data you need. So that's our goal. Questions so far? General overview? Good. Haven't really said anything yet. Great. So there's a number of built-in integration features. I'm just going to go over those initially. When I say built-in, I mean, they come as sort of part of the product. You interact with them directly oftentimes. There's, user-facing components. And those are going to be our immunization messaging features. I'm sure some of you guys are familiar with that. Our electronic lab results features. Direct secure messaging. DSM, we use UpDocs as our HISP for that. I'm sure some of you guys use that as well. And clinical document exchange, specifically through Care Equality. So let's look at those individually. Immunization messaging. So this is one we've been doing for a long time, right? Even before there were good standards for it. Romney in the back has been mangling integration messaging since it was just weird, fixed length character CSV stuff for every state for however long. We're in a better place now where there are national standards for integration messaging, and obviously with national standards, no one ever follows them perfectly, so we still do a lot of custom work between different states, but nonetheless, there's a pretty good baseline for what immunization integration looks like with each state. One of the major integration models for IIS is Immunization Information System. One of the major messaging models is administration reporting. That's a message type called HL7VXU. And we've been doing forever. I imagine virtually everyone's practice is doing that in some capacity, right? That's what enables you to, upon marking an immunization administered in the EHR, to have that queued up and sent out the door automatically to your registry, or when you update it, or when you mark it canceled, et cetera, et cetera. That's sort of the critical immunization message, because that's what keeps public health agencies and so on in alignment, and lets them aggregate and understand the full picture of different patients' immunization histories. More recently, we've been going strong with the HL7 QBP, the immunization query message type. People often refer to that as bidirectional messaging. The implication being, if you're already sending, this is how you then receive or pull immunization histories from your IAS. That one is more recently adopted by the different immunization jurisdictions, and it's most recently adopted by PCC. Jen, do you remember when we first introduced QBP? 2 years ago now? Somewhere in COVID? Yeah, that sounds right. But our goal over that time has been, since we introduced the functionality, to roll that out, because you have to implement it per immunization jurisdiction. It's not like you do it once and it works for everybody. So we've been going down the list with everybody that we already submit VXUs to, and making sure that we can query them as well. I think we're about between 60 and 70% through the list, so we're still working through some states where it's either harder to get a hold of them, or it takes longer to onboard, or whatever it is. If you've got questions about your state, come ask us afterwards and stuff, because chances are we're either already working on it, or it's a few steps down in the list. But we want to get everybody doing immunization querying as well. And there's also, not only do you pull the history with those, but you also pull forecast. Obviously, we have a separate forecasting component in the EHR, but, that's part of the transaction. Acknowledgement processing and review, the HL7 ACK message. This is mostly for the VXU side, right, the administration reporting. But if your state provides compliant acknowledgement messages, we will then display those in the EHR, and you can look at those in the what do we even call it? The Immunization Registry Response Viewer, yeah. And it's good to review those and see the state of your immunization submissions, because if there's some error reported, whether it's actually causing a rejection of the message or just informing you that the email is weird as it's been entered or something like that, and therefore it's not going to be stored. It's great to be on top of checking those and seeing if you need to resubmit an immunization or go look in the IAS system to make sure everything looks okay. And yeah, as I mentioned, PCC's goal is to support all available transactions with all applicable jurisdictions. So any immunization registry we can query, we want to submit VXUs to anyone we can, and so on and so forth. Questions on the immunization world so far? Good so far?
I don't have bidirectional yet, but how does it work if they're giving you forecasting, but you've got your own little box of forecasting? Where does that other forecasting
Where does it go? Yeah. It's separate, and it only displays on the screen as part of the actual, when you press the button to retrieve the immunization history, it also shows the forecast. So it's in a pop-up window. It's not persistent in the chart the way that the common forecasting is. And this is for a number of reasons. One, we've found in general that I'm trying to think of how to say this diplomatically. Yeah. It's better to have one consistent forecasting point than jurisdictional. Yeah, great question though, for sure. And if you haven't seen the query workflow, there's some great articles on Learn and videos and so on about how that part works, and how you compare IMs to your existing IM history, and just import the ones you want based on CVX and date and that kind of thing. Which jurisdiction are you guys in? Texas. Oh yeah, MTRAC. Woo! We're gonna have a whole talk about that later, right? Okay, cool. Yeah. That's a party. All right, great. Any other ones on immunization? Cool. Thanks. All right, lab results interfaces, right? These are achieved with a message type called HL7 ORU, unsolicited observation message. PCC currently supports results interfaces with between 60 and 70 labs. Labs are always kind of buying each other and coming and going, so it's hard to pin down the exact number, but somewhere in there. We're going to continue to develop more connections as requests emerge. So these ones, are another case in which there's no one silver bullet for being able to get results from every lab, right? Each individual lab that folks want to get results from, we have to get in touch with the lab, hammer out the integration details, how they want to transport the results to us, look over the content of their results, make sure they're compliant with the lab results excuse me, implementation guide that we've used as our standard, and then get them all set up for you. So if you have labs that you have a high volume with, that you're interested in PCC pursuing a connection with, let us know. But we've supported the quote-unquote big labs for a long time, the Quest and LabCorp, Diatherix, and other major ones as well. And these all come in, and then you process them through your eLab import queue, so on and so forth. We also support demographics bridges. We'll talk more about that later, to lab ordering systems. You guys are probably aware that we don't have electronic lab ordering yet, so oftentimes there's a supplemental application that you have to use to place the orders. But we support sending patient demographics to those systems so that they can be pre-populated, and you just select the patient and place the order, and so on and so forth. Yeah, questions on labs so far? Cool there? Okay, great. Direct secure messaging, yeah. So, do you guys use direct secure messaging? Yeah, DSM, UpDocs, cool, great. Yeah, so under the hood, it's just an encrypted email standard. It's just sort of the encryption keys are really tightly managed. It's commonly used to transmit attached documents, which can be, often include HL7 CCD, right? That's a continuity of care document. PDFs, containing all sorts of stuff, scans or summaries or so on. XDM, that's a, what does that even stand for? Cross document media, something. It's a zipped bundle of stuff that has a CCDA in it typically, and more. And this is for the use case of user-to-user sort of push-style information sharing, right? This is, those of you guys who use it know you have to select a particular direct user that you're trying to send the document to. You attach whatever it is, a transition of care summary, something like that, and send it out to someone else who's supports direct secure messaging through this or that HISP, and so on and so forth. And it's ideal for directly notifying and sharing data with care delivery partners. So a lot of folks we've seen recently use DSM to share sort of trigger event-based admission or discharge or status update messages from a hospital system or something like that. That's what we see coming into PCC practices a lot. Yeah. I've seen a lot of pretty filler, spammy stuff over DSM, but I've also seen some folks who use it, more specifically, and it really depends on who's on the other end of the line and how much you've communicated with them about what you want to receive and so on, it seems. But for sure, a lot of big health systems just will blast, anytime Timmy showed up, here's a text blob of like, Timmy showed up, and here, and you get a, yeah. So, a lot of the times those health systems will also support some alternate notification system for those types of notifications. So I've definitely found myself advising people, like, if you can do that via just text alert or something else, you don't need to clutter up your messaging queue with those kinds of alerts. You can save them for real clinical summaries.
Okay, but there is no HIPAA ramifications for deleting a direct secure message that gets pushed to you?
For deleting it? Not that I'm aware of. I think ultimately it's totally your. Yeah. I think it's your call what you do with the contents of the DSMs, for sure. Any more questions on direct at the moment? Cool. How are we doing on time? Oh, yeah.
Is it already built in that asks for service?
Is it built in, you asked? Yeah, it's built into the product. It does have to be enabled, and you have to do some identity proofing stuff, for your practice to be a vetted direct user. So you do some stuff with UpDocs, but we provide, there's plenty of documentation on how to get through that. We implement it very frequently. It's not super hard. But it does come baked into the product. You just have to do the legwork around it. And once it's on, it's just, it's sort of all automatic and just coasts in the background. All right. Clinical document exchange. This is a more recent one. And this is a specific kind of clinical document exchange. We've shortened the name to just clinical document exchange, but initially, and the official name is query-based clinical document exchange. So while we may push clinical documents in other methods like direct, or in some cases like an automated SFTP feed, which we'll talk about later, this clinical document exchange refers specifically to cases where you are able to query other organizations for what clinical documents they might have on your patient cohort and download and potentially reconcile those documents. And likewise, they can do the same for you. We accomplish that through the Cary Quality Framework. If you haven't ever heard of those guys before, you can look them up. They were originally part of the Sequoia Foundation, I guess it's called, which also has the eHealth exchange for sort of federal and HIE-based document exchange. They've since split off because of various things around TEFCA and so on and so forth, but nonetheless, Cary Quality is the document exchange framework that we use for supporting this standard. Again, the documents being exchanged here are of the CCDA variety, the Consolidated Clinical Document Architecture. The exchange is query-based again, so this is a pull. This is one where you get a directory of other organizations who are part of Cary Quality, either as implementers of the standard themselves or as connections who have been onboarded via a particular implementer. The semantics there are a little funky. In our case, PCC is the implementer because we have all the web services and do all the computy stuff, and any practices we onboard are Cary Quality connections. So you get a directory of the connections that you can query. And then you can, while you're using that, select which connections most apply to your workflow, so you don't have to broadcast against the whole directory anytime you want to see if patient information is out there. So if you have a few local hospital systems or a practice that you have a lot of crossover with in terms of your patient population, you can sort of select those as your defaults to query. And then when you're in the patient chart, you can query them and it'll return a list of available documents that this or that practice has posted for that patient. You can then select which of those documents you want to download and reconcile the elements from a potential CCD into the chart. It does require... The reconciling, it'll work if the CCDs are structured appropriately and have the components that are reconcilable. Right now, our reconciliation, I think, only supports what was required during Meaningful Use 2, which is something like problems, allergies, medications. I think that's it, maybe one more. But we'll be looking at adding more to that. We'd like to get immunizations reconcilable as well in the relatively near future. But yeah, a lot of people do reconciliation through this. If you have issues with reconciliation, we can definitely talk about those as well, and check out some examples and so on. That's a problem you're having through DSM right now? Like people send you a CCD and it doesn't reconcile?
I have Cary Quality.
Oh, okay, cool.
It's just, and it looks blue and yellow just like everything else.
Yeah.
But then I put reconcile, it's like, haha, I just want it.
Okay.
Doesn't do anything.
Yeah, we can look into that for you, for sure. Yeah, so one thing to note about this is that to join up on this, there are a few sort of administrative considerations. You've got this Cary Quality Connected Agreement that you have to sign. It's not a huge, selling your soul kind of thing. It's a one-page document that, sort of describes your obligations as a Cary Quality connection. And notably, Cary Quality's policies are that you sign on as a responder if you're going to query out into the Cary Quality community, so that you will make your patient cohort documents available for querying from other Cary Quality connections. Currently, there are various purposes of use for querying in query-based clinical document exchange. PCC only supports treatment currently. That's the only one required by Cary Quality, but they are looking at adding additional purposes of use, including a patient querying for their own information. So that's like if you have one of these PHR health apps or something like that and want to, aggregate your own health data from a variety of systems. And I think there's some other population health ones that Cary Quality is looking at approving So the purposes of use we may need to expand in the near future. Currently, it's still only folks who assert that it's for treatment purposes. As part of uploading your information and making it available to be queried, there's a data sharing policy pre-configuration. So we support opt-in or opt-out, ultimately however you guys want to manage your population based on whatever your sort of jurisdictional requirements are, and we will only serve up documents for patients who have explicitly agreed to share their information. But there's some work you have to do to create those settings before you go live. Cool. Any questions on query-based clinical document exchange? Yeah. Yeah, I mean, in general, the idea is, yeah, this would be based on the permission granted by your patients, but that's also, again, that has to do with your sort of regional, state, jurisdictional, whatever the requirements around data sharing are. So you can set a global policy, we do, let's say, we're an opt-out state, so meaning everyone is opted in unless they explicitly say, don't share my data. You can set that as a baseline, and then as you ask patients, if you have a questionnaire or whatever you do as they come in, you can individually identify patients who have opted out, and that'll sort of flow over to our document repository and update them as don't share. Or you could do it the exact opposite way, however you like to configure it. So that's the bullet point there, is figuring out how you want to manage the consent piece based on whatever your sort of specific requirements are. Carrier quality? Yes. Yep. Yeah, just let us know if you want to do it. We onboard people pretty rapidly, I think. It's not terribly hard to get folks up and running. Really, the trickiest part is the pre-launch administrative steps. It takes a while to get everybody on the email, doing whatever they're doing. If you have to, some people feel like they want to consult with legal counsel before they do the data sharing policy implementation, all that stuff. So getting the pre-work done is the tricky bit. Actually turning it on is quite easy. Yep. Yeah. Yeah, thanks. That last question was, is clinical document exchange via carrier quality available now in PCC? And it is, yep, for sure. Yeah. Though it hasn't been widely adopted yet. I want to say we only have between 20 and 30 practices using it currently. Yep. Any other ones on this? Okay. How are we on time? Is that accurate? That looks like... Okay, yeah, cool. Great, thanks. All right, so supplemental models, stuff that's not necessarily built in or sort of user-facing. And we do a lot of these. A substantial portion of the work that our team does is working with third parties and setting up these various supplemental integration models that are sort of back-end, if you will. They're stuff where we're creating automated pipelines through which your system shares data with a third party you've identified. And the question is often, what data do you need to share with that third party, and how can we meet that need for you? So we're going to look at a few examples of that here, and then as I do that, I'll probably remember some random ones I forgot to put on the slides, and I'll try to speak to those if I do. The first one, as we alluded to earlier, is the demographics feed, often called the demographics bridge. I don't know how that nomenclature came about, but you'll hear it described either way. And that's often, well, we'll get to that in a second. There's a scheduling data feed, which we've only really started using a lot in the last maybe 2 or 3 years. We had some experience with it previously before the EHR existed, when we were just doing partner, and we'd have scheduling data feeds with other EHR systems, but since having the EHR, we haven't needed it. But we've had some application interfaces recently, which have used that again. Clinical document feed, so this is going to be using that same consolidated clinical document architecture standard that we use for direct secure messaging, for query-based clinical document exchange, but this is just sort of a back-end automated push of those documents. Claims data, that's fairly self-explanatory, but we'll go over the details, and automated CSV exports, which are kind of the boogeyman because they lack standards. So, demographics feeds, right? These are HL7 ADT, that's admit discharge transfer messages. The name is a little bit misleading because it comes from a hospital context where these are being triggered by those various kinds of events. But this has also become the de facto standard for just communicating demographics changes and that aren't necessarily associated with a specific sort of inpatient event. And as such, for us, we just support new patient registration and demographics update-based triggers. For anyone who cares about HL7, those are AO4 and AO8 transactions. Excuse me. And these are typically used to populate, demographics in a third-party system or application, most commonly with lab integrations for ordering applications. Though we've seen other ones, some, immunization inventory management applications, and really, any other application that wants to precede their system with the demographics before allowing, user-based access to it. These are often used in combination with clinical document feeds for HIE connections. So HIEs will request that we set up a demographics bridge and then additionally a clinical document push so that they get the demographics and sort of hammer out their patient index first and then associate the chart data that comes in the clinical documents with their preceded patient cohort. Based on the requirements of the third party, these can include insurance policy and guarantor information, but it kind of depends. Different outfits like different stuff in their demographics messages, so we sort of customize that to what folks want. Solid on this so far? Cool. A scheduling data feed. This uses the HL7 message type SIU. That's scheduling data unsolicited. Maybe it's supposed to be scheduling information unsolicited. I'm gonna call it that because that makes the letters make more sense. But either way, we automate this with based on triggers in how you guys are working with the appointments. We send create, update, and delete based triggers. Delete go through as a cancellation, but so when a new appointment is created or something about it has been updated or it's been deleted or canceled, that fires off a message to the recipient of this feed, letting them know the status of the appointment and any sort of contextual information about it. There's some demographics included in this as well, right? You get some basic sort of what's the patient's name and address and so on and so forth associated with the appointment. These are used primarily with third-party systems that are looking to track encounters in close to real time. So we've seen this, again, for a vaccine inventory management system. Do they get SIUs? Yeah, they do. As well as for a post-visit survey application, stuff like that. It includes some minimal demographics. I'm repeating myself now because I think about the same stuff I thought about when I was writing it. Yeah.
Is this an example of something that can be used to have patients self-schedule appointments? Because we have to use a third-party system for that.
The could is yes. Yeah, sorry, he asked about the use of a feed like this in integrating with a self-scheduling application. Yeah. So I mean, the could it, yes. The does it depends on what the third party supports and how they integrate. But for sure, this would probably contain the kind of information. The issue with this one is this is strictly outbound currently, so this wouldn't schedule anything in the EHR, but it could certainly be populating another application with whatever data was entered about the appointments. Yep. Yeah. Any questions besides that on the scheduling data so far? Yeah.
That's the question. Is there any plans to do outbound so that we can then interface with those, or inbound, I'm sorry, so that if we are using online schedulers, we can get that data populated?
Not that I'm aware of, at least not in the scope of our team's operations. And this is a little tricky because typically we deal more in the realm of transmitting clinical and chart data. We've sort of dabbled in this as well as a stopgap measure. There are folks who are looking into patient self-scheduling and checkout and so on and so forth at PCC pretty closely, but I don't know where they're at with it. So I apologize, I can't give you that one, but I'm sure someone around this conference can give you a better answer than that. Yeah, other questions? Cool. Clinical document feed, right. So it's HL7 CCDA again. These are encounter-based triggers, so that's slightly different than some of the other. They're nightly exports and transfers. So I mean, the way this looks is there's an automated job that runs, let's say, at 11 p.m. every night. It scans through your daily data for any patient who had an encounter that day. It generates a clinical document summarizing that encounter, and it sends it to the designated third party who's collecting this incremental data. We also support what's often referred to as a longitudinal clinical document, which we'll typically use to sort of precede a third-party system with the entire chart for a patient cohort. So that's not encounter scoped; it's sort of full chart. But then for the incremental updates, we base it around encounter. Those are typically used by HIEs, CINs, ACOs, anyone who's collecting a lot of clinical data for, whether it's population health concerns or clinical quality measures, HEDIS stuff, any of that. Because it's pretty, the CCDAs, compared to these other sort of narrowly defined message types are, pretty robust. They contain a lot of data. And one thing to note is that this is pulling primarily from the EHR itself, from the clinical side of the software suite. This doesn't include, a bunch of CPT codes and billing data and that kind of thing. That's typically handled separately. Yeah, questions on this one?
When you were talking about third party as far as scheduling, does your clinically integrated network have to be something you guys have already built? So if I have a CIN up there, we don't have a ton of WIP, but it would be cool if we did. So do I have to have a CIN that you've worked with already?
You can check with us about it. Typically, if it's a brand new connection and if they do support our standards, there's often like a one-time implementation fee to get set up with them, but it's usually pretty negligible based on what data needs to get exchanged. And basically, if they can support a connection, we'll work with them to build one. Yeah. So just on that, Sarah. Oh yeah, sorry. The question, should we have a mic or something out in the crowd? Okay, cool. Yeah, the question was if someone wanted to use, let's say, the scheduling data type to connect with a CIN that PCC is not yet interfaced with, can we do that? And the answer is generally yes, and we get those kinds of requests all the time. We're constantly building, interfaces with CINs, all the letters. Yeah. Cool. Yeah, it doesn't pull in billing data. And based on who your CIN is or your ACO or whatever it is, these folks will often want different sort of combinations of these. I was just, is Lauren Leopard here? No, I don't see her. But, we were just talking to Community Care of North Carolina or Community Care Physicians Network. We're doing a similar thing with them where they're getting, a document feed like this one, as well as a few supplemental feeds for appointments and I think billing diagnoses and that kind of thing. Some other folks might want just the ADT and then a CCDA, et cetera, et cetera. So we kind of work with them and figure out what they want to ingest and what standards they support and take it from there. All right. So this one doesn't include billing data. That's not to say we can't send claims data. We sure can and do oftentimes. This is, we send 837 professional claims format files to them, and the thing about these are they are the exact same claim files that you guys submit to payers to get paid. And when I say the exact same, I don't mean we reformat them and recreate them. I mean literally the files that you guys sent to payers as part of your billing workflow, which get archived on your system for a set amount of time. This kind of interface just goes and takes those and passes them along to whoever it is, your CIN or whoever you've designated to receive them. Is the jet sound going to kill the? Can you guys still hear okay in the world of the internet? or whatever, whoever we're talking to? We're good? Okay, cool. So yeah, much like the transport method with the CCDAs, we do this via nightly secure file transfer. It's pretty simple. It just takes whatever claims were submitted that day and says, here's what claims were submitted this day, and they can scan through and mine whatever data they need for your quality measures or what have you. This contains all build CPT and ICD-10 codes that would not have been available necessarily in the clinical document feed, so it's often used for that. But the other side is it doesn't contain the more robust clinical picture that the clinical documents, which are made to convey that, do. And yeah, we've seen this mostly with CINs and related organizations in conjunction with other quality measure data that they collect through other integrations. This one's, I think, pretty straightforward. This makes sense to everybody? We're good on that one? Okay. Great. And we've got plenty of time, so I'm just going to, should be getting to the end. Automated CSV export. Yeah. All right. So the fun thing about healthcare standards is that there are plenty of organizations that have a big market share that just don't use them. And that makes it such that for a lot of especially sort of big clinical quality population health sort of application vendors, they just want to define custom CSV, character delimited value files, where they, sort of decide what the data model they like to use is, and then they request that you be able to custom export that data model. It can contain clinical and billing data. It can be trickier to maintain than standard interfaces because they're non-standard, and therefore if the third party just up and decides to change what they want in the feed, there's work that has to go into, re-backloading with additional fields or whatever it is. Typically used by quality analytics vendors who aggregate tons and tons of data. So this is for outfits who say, CCDA is not really good enough. We want to make sure it has X, Y, and Z, and we have a template, a series of files that cover the core domains you might imagine. Demographics file, a problems file, a immunization file, medications, allergies, et cetera, et cetera, et cetera. But different vendors will want slight tweaks to it, or in some cases a different format altogether, and we just kind of have to work with them directly when it's really a matter of need. We like to avoid this whenever we can, but it, oftentimes it is what's required. The other sort of dark flip side of this is there are some vendors who will require, or at least request, instead of getting anything exported, they just want direct access to your database and so on and so forth, and that always is a complex thing to negotiate and figure out. So this is kind of like the last resort, in a way, of interfacing with a vendor that just doesn't support established healthcare standards for data exchange, which are more than you'd expect. Or maybe exactly as much as you'd expect. I'm sure there are other cynics here. So does this make sense as well? It's pretty straightforward also. Just CSV is defined by this or that, folks. And I think that's the bulk of the types that I wanted to talk about today. You can, if you're interested in placing a request for an interface or integrating with a new third party, you can check out who we already interface with at that top link there, or rather at the bottom link, at the connections link, and on the interoperability page, there's a link to a place where you can submit a request for a particular integration if you're interested. And I think that's all I've got in terms of slide material, but I'm happy to answer more questions or complain about immunization jurisdictions or anything you guys want to do for the next couple minutes. Yeah?
With the LabCorp, do you have a bidirectional interface?
I'm sorry, could you ask that one more time?
With the LabCorp?
With LabCorp?
Yeah.
No, we don't. We don't have orders interfaces currently for any lab vendors. We are currently reviewing the way that we handle eLabs in anticipation of developing that functionality. So I don't have an ETA on that yet, but it will, if and when we do develop it and bake it into PCEHR, it'll probably be Quest, LabCorp, everyone else in that order. Yeah.
I realized as I went to ask this question that it may be about something that is a step beyond what your scope
Sure.
or like what exactly you're working on. But similarly with LabCorp, when I get labs, I'd love to like immediately make those labs visible to my patients. Is that functionality already built into PCC, or like the way the screen that it comes in on doesn't give me an easy way to make that immediately possible? And usually my nurses will go into LabCorp's own website and like download a PDF of the labs from their site and then make it visible to the patients.
There's,
Like-
yeah.
That may already exist and I just don't know.
It should be possible via the portal, but hold on. Let's get Rami a mic there. Yeah.
As soon
No,
as,
it's great.
Yeah, no, as soon as your lab results are linked in the patient's chart, if they're electronic lab results that you're receiving, they are immediately available in the portal. And in some cases, in some practices, they don't want them immediately available, so they tend to check the box so that they won't be immediately available. And then when they're ready to have them available in the portal, they will uncheck that box so it's available. So yes, it's immediately available when they're linked to the patient's chart.
Sends the results in pieces, like multiple items. And if the patient asks for a report right away, like Quest has one PDF file, for LabCorp it doesn't have it. Is there any way you can consolidate them into one PDF?
What you're referring to, it sounds like bundled results, and not all of them are final results, maybe, or they are, but they come in one at a time. Well, you're printing it and then making it available in the portal? You should be able to. Right. Because there's 10 results coming in, and
Yeah. Can folks who can't hear currently, the question is about the bundling of lab results as reported, whether they're individually reporting each test as its own result message or sending back a broader one with a lot of tests sort of nested in it, and Quest doing it one way and LabCorp doing it the other way. We don't have a method of sort of circumventing that currently, because the way that the results are reported to us are, more or less the way we have to present them. Especially with Quest and LabCorp, they have some pretty strong feelings and specifications about exactly how you display the results of the labs. I imagine as we dig deeper into ordering and so on, we'll look at optimizations for potential display groupings and stuff like that. But as of right now, the best way to affect any kind of change in the way that the lab results come in is to talk to the lab themselves. If you'd like to have more things batched together or so on and so forth, because we ultimately have to kind of ingest and display what we get from them in the level of specificity that we get it.
Interestingly, if we go to LabCorp web portal, or patient portal, it'll come as one document.
I believe
don't
you, yeah.
know why.
Yeah, I don't doubt it for a moment. And I don't know offhand if that's something that you can get LabCorp to change on a per site basis in terms of how they report the results. But
In another EMR, there is a button to bundle all of them into one document.
bundle it in one document. When you say document, you mean like an exportable PDF or
Yes.
something like that?
Yeah.
That's interesting. Yeah, we could look into something like that, aggregate for display or printing. Yeah. Sarah?
For anyone who has a wish that we haven't answered, go to the wishing well in between courses, and they'll write down your wish. So I heard a couple already this session, but we'd love to get those down in writing, and the wishing well is the place to do that. And they're set up at tables on your way to the other classrooms.
Great point, thank you. Yeah, because I'll sit here and say, that's interesting. Yeah, we could work on that. And then someone will ask me the next question, and yeah, appreciate it. Yeah, any other thoughts, questions? Feeling good? All right, then I'll wrap and give everyone their 15 minutes back. Thanks, guys. Appreciate it.